All yours.
Thank you very much, Kevin. It's a delight to be with you today. As I set this up, just a quick comment. The last I checked, typical hospital had about 1,600 required measures from various regulatory oversight bodies. At least Intermountain, we were about a $5 billion system, about $20 million a year in true cost to generate those. Interestingly, many of them were from different groups and were slight twists on the same metric, but different enough that we couldn't report them as a single system. But I'm going to argue to you, though, is it's fundamentally a design issue. Ed Deming said it best, AIM defines the system. I really want to look at two different views of healthcare. Outside in, which usually relies upon selection and ranking, versus inside out, which is what you do if you're actually going to do change or improvement, care delivery management. I'd like to refer you to a paper that Don Berwick, Molly Coy, and I published back in 2003. We were part of the Strategic Framework Board. We were called together to advise the newly formed National Quality Forum about the evidence behind quality measures. And this was part of our report. Don actually generated the graph. So pathway one, selection, purpose goals, results about performance. Your aim was selection and accountability. So you wanted knowledge about performance with the target audience of consumers, purchasers, regulators, patients, and so on. Pathway two is actual change, measurement for improvement. There you needed knowledge about processes and their results, where your primary target was care delivery organizations and the teams who delivered the care. Now, in theory, there was a motivation factor that was working between the two. But the point was, is you get two very different aims. The point, that different aim defines different data systems. In some ways, radically different data systems when you're putting this together. Well, I'm going to brush through these quickly. I put a lot of details in the slides, far more than I'll cover. Trouble with measurement for selection and ranking, I'm happy to defend this. Turns out they can't rank accurately. It's an underlying mathematical problem. There's a fairly strong literature behind it. It has to do with the width of confidence intervals associated with ranking measures properly calculated. Very often those ranking measures will cover a confidence interval that will cover 2/3 of all ranks, for example. It tends to shift to a focus on documentation, as been mentioned earlier. It rarely includes the measures that are essential for change. It's usually completely incomplete. And at the same time, it consumes large amounts of resources, all right? Leaving no resources for actual performance management and improvement. Measurement for selection, well, the interesting thing is that very often actively damages quality of care in the name of quality of care. It's a design issue. I understand it's an unintended consequence, but I think that people ought to take the time to understand the system before they impose measures. On the other hand, measurement for change or learning generates a very different data set. They tend to be quite parsimonious. You avoid recreational data collection, avoid availability bias. It minimizes burden. It turns out they're the sorts of measures that you can integrate into a clinical workflow. And the crazy thing is they contain selection measures. In fact, you can argue that the best selection measures you could possibly generate come out of this sort of a system. So what I'm really saying is, back with that original chart, it's a one-way street. If you build for change or improvement, you get selection at an optimal level for free. But it doesn't work the other way. If you build primarily for selection, you actively damage care management on the other side. And it turns out you can't do it accurately. So that's the point behind the whole thing. What you end up with if you go for measurement for improvement is a series of registries. Disease specific, they tend to be system-wide. Intermediate and final clinical and cost outcomes. Your primary aim, though, is to support care delivery. Secondary aim is accountability. I'd like to give you a really quick case study with a trick in it. Type 2 diabetes mellitus, we had about 60,000 patients, about 90% of all care delivered through primary care, supported by 6 endocrinologists, just in passing. It was a fragmented system, mostly community-based providers. What I just wanted to make the case is we showed a dramatic improvement in care in terms of intermediate measures like poor hemoglobin A1C controls. This was an actual trial, a full-blown trial for complex diabetics, improvement in survival, dramatic drop in hospitalization rates, translated into dramatically lower costs of care. Well, we did this with 4 tools. And when we deployed them in what's called a factorial design, so I could measure the impact of each factor. Action list, patient worksheets, comparative outcomes, and financial incentives. Now, just to warn you, I'm going to show you the tools, and I'm going to ask you which of these were most effective in driving the change that I just quickly showed you. All right? That's what I'm going to ask you. Action list. It drives off the registry. It just lists every diabetic patient in the practice's patient body. For each patient, it shows anyone who's not up to speed in testing rates and testing levels across the measures associated with diabetes. Most practices generated about monthly. Typically a nurse, sometimes a physician would go through it and reach out to patients who needed care. It means that you weren't treating the care as episodic. You got a continuous care regardless of whether the patient showed up in your clinic or not. Patient worksheets. This is a made-up example of one. Turned out to be really popular with the clinicians. Patient demographic information, a problem list, problems and chronic conditions that drove the rest of the report, full medication profile, preventive care summary, labs pertinent to those problems, in this case diabetes, exams pertinent to the problem list, in this case diabetes. We called them passive reminders. They were really orders. But because clinicians routinely need to be able to vary, we didn't want to perjurate them by saying they were orders. Most of the clinicians would check them off as orders. Turned out to be really, really popular, but that was tool number 2. Tool number 3, comparative outcomes. This is a real report from Dr. Stephen Towner. I used it with his permission. A Mayo-trained general internal medicine specialist with a very large diabetes practice. This shows testing rates up here to the top left. Now, Steve's the blue bars, his regions, the green bars, the system as a whole are the red bars, and then these show level controls. So for example, for hemoglobin A1Cs, only 4% of Steve's more than 200 patients had an A1C of greater than 9, high risk area. Almost 70% were under 7 in the ideal setting. See the idea? But those were all covered as well. This is the version of the comparative report that went to your medical director. My joke is if you weren't doing well, you could be invited to lunch by your medical director. More on that in a minute. We finally tied it to financial incentives. It was a one measure among a set of measures, but always a fairly strong component of about a $3,000 plus or minus income swing. So you've seen the 4 measures. You've seen what it produced in terms of dramatically better patient outcomes. Frankly, across 60,000 diabetics with 6 specialists, we were achieving levels of performance that would compare favorably to any specialty practice. Is what we were seeing. My question for you, could you please show the poll? Which of these 4 drove primary change? Show us the results. Yeah, interesting. Turns out the first 2 were over 90% of the change. We included comparative outcomes because people are so interested. If your medical director took you to lunch, what they actually would have said is, we know the process. Oh, about 80% of the work happened at a practice level, not a physician level. We know the process by which you can achieve better diabetic care. Can we come in and teach your staff how to support you that way? We threw in the financial incentives just because it was fair. Essentially 0 impact. Right there on that result, we understand the design problem. People have a fundamentally, profoundly mistaken view of what drives care. I just wanted to show that we applied this more broadly. Trial of about 150,000 patients. We invested about $22 per member per year. Our actual medical expense fell by about $115 per. This is more than a 5-to-1 return on investment with better clinical outcomes. So, yeah, the key functional elements, a design question, you want transparency at the front line. All right. You want to primarily focus on execution and improvement with a secondary aim of accountability. And it's just a fundamental difference in approach. And with that, thank you for your time. I've added some extra slides if you care to look at the slide packet. Back to you, Kevin.